Welcome to Hidden Diagnoses Impact, the podcast where we bring light to conditions often dismissed, misdiagnosed, and misunderstood. I'm your host, Amy Wang-Hiller, a violinist, advocate, and disabled creator. For each episode, we bring stories and insights from patients to caregivers and healthcare professionals navigating the hidden realities of complex conditions like EDS, CCI, and beyond. This podcast is part of a larger mission. We are building several initiative programs dedicated to bridging the equity in music and health. We aim to amplify the experiences of those often left unheard and unseen. If this resonates with you, consider supporting us at this early stage. Become one of these founding supporters. More information, please visit inclusivibe.betterworld.org. Your contribution will help us to grow this platform for real patient-led and physician-informed solutions. Today, we are joined by Dr. Colin Halverson. Dr. Halverson is a faculty investigator at the Indiana University Center for Bioethics and an assistant professor at the IU School of Medicine. Dr. Halverson holds a PhD in linguistics and medical anthropology from the University of Chicago, where he conducted fieldwork at Mayo Clinic, focusing on communication challenges in medical genetics. He also completed a fellowship in clinical ethics at Chicago and later a postdoctoral fellowship in medical ethics at Vanderbilt. His work seeks to bridge the gap between ethical theory and the real-world applications in diverse medical settings, contributing to a deeper understanding of the cultural dynamics that influence health and wellness. His recent research is dedicated to explore ethical care for patients with rare diseases with a particular emphasis on Ehlers-Danlos Syndrome. So join me and welcome Dr. Colin Halverson.
Hi, thank you very much for having me.
Yeah, so I know that your work has increasingly focused on patients' experience, particularly in rare diseases like EDS. So can you share some of what led you to explore the intersection of ethics, genetics, and the frequent dismissal that the rare disease patients face? And additionally, of course, what inspired you to specifically focus on the EDS community?
Sure. So as you've already mentioned, my background, I think, does not look like the typical person who ends up in this space. But I was really interested in communication in medical genetics while I was in grad school because of some work that I'd been doing on the south side of Chicago with a biobank, so a repository mainly for genetics material. And I realized in that moment that I wanted to shift my focus in my dissertation from something that was more on the theoretical aspects of language and more towards the ethical and practical implications of language for communication in these types of spaces. And I was incredibly lucky to get a postdoctoral fellowship at Vanderbilt, where I got to continue expanding on the initial work that I'd done at Chicago and at Mayo. I started thinking about this as a career instead of just a project. And one of the things that I had to reflect on at that point and in the transition to Indiana University was, where did I think I could be most helpful? And where did I think that my interventions would be most impactful? To quote a famous podcast. So the reason that I'd always wanted to focus on Ehlers-Danlos Syndrome, because even while I was doing my field work, I was recognizing that there were really different ways that clinicians were treating patients with chronic pain disorders versus other types of genetic disorders. And Ehlers-Danlos in particular among those, I thought, was receiving a special neglect or dismissal. Then when I came here to Indiana University, I had the incredibly serendipitous opportunity to work with Dr. Claire Francomano, who is one of the world experts in the genetics of Ehlers-Danlos syndromes, who happened to start here at exactly the same semester that I did. We both joined the faculty at the same time, and she opened up an Ehlers-Danlos clinic here. So I was kind of ground floor with that. At first, I was kind of nervous even asking her because this was a pipe dream for me, and I had no idea if she was going to be amenable to kind of the social and ethical research that I wanted to do with the population when I'd seen so many other clinicians be uninterested and maybe even hostile towards this type of engagement, especially with Ehlers-Danlos. But incredibly, she was very interested, and I've been working with her and with this kind of growing cohort of folks with EDS over the last almost 6 years now.
Oh, that's incredible. I think it's just like timing and everything just meets together. I'm really interested in those EDS clinics. I know that a lot of my folks that I met always feel like there was lack of resources, and they are the one try to find ways to diagnose, almost like they diagnose themselves. Often saying before the physicians even like be able to diagnose them. So I know that previously you worked on the EDS populations and realizing some kind of traumatizations going on with physicians like dismissal. So I would say, like, can you elaborate a little bit on this fact, like the impact, how the physicians can manifest when they do have those kind of dismissal or gaslighting behaviors?
Yeah, I can. So this was really a moving project that I ran, moving for me. Um, I think 2 years ago, maybe 3 years ago now, with my cohort of folks with hypermobile Ehlers-Danlos syndrome. Right now, I'm looking to see whether there's comparable psychosocial experiences for patients with other types of EDS too. I think I'm very actively trying to expand beyond the hypermobile cohort because I think there are some both critical differences and some really important similarities in experience that I'm trying at the moment to define. But the data that I'm going to be talking about right now is all based on hypermobile patients. So we did these interviews. I did these interviews with folks about their experiences with clinicians. And the reason for that was I'd done an earlier study looking at the diagnostic course or the diagnostic odyssey that patients have to go through to get an HEDS diagnosis. And one of the things that was really striking in all of these stories that I heard was the incredibly negative responses that they were having to the relationships they were developing with their frequent visits to healthcare providers. And I wanted to explore that more closely. There was a lot of conversation about trauma already in the initial interviews, but when I dove specifically into that as a topic, every single one of the patients I spoke with had some experience, at least one experience that they found to have lingering trauma-like effects on their psyche and on their relationship to healthcare provision. Um, the traditional way about thinking about PTSD was my initial impulse to make that kind of a comparison. But one of the problems I thought, and in consulting with other folks who are on the psych side of medicine, uh, that limits its applicability to at least all of the cases that I was hearing, is that so much of the focus with PTSD is on both singular incident that leads to the trauma, and also that the trauma specifically relates to some brush with death. And while certainly some of the patients I spoke with did have both of those, would have had both of those boxes ticked, um, all of them didn't fit that. And what I was seeing more was that there were these very strong parallels to PTSD symptoms, but they were arising under different conditions. Specifically, patients had a cumulative impact of all these negative encounters with clinicians. And this is really important because a lot of them we're not having these massively bombastic, obviously terrible encounters that a lot of times you hear about. Um, but we're having just this accretion of all these small negative encounters, dismissals, micro-invalidations,
Um,
toxic positivity that would build into this. Um, and certainly it was not requisite that the patients had a brush with death to have this very similar set of symptoms. So we call that clinician-associated traumatization. We go into it in a lot of detail. It's in social science and medicine. If people are interested, it's open access. That's another thing that I try to do with all my publications. So nothing's behind a, kind of like ivory tower firewall. So
mhm. Yeah. So I kind of spoke with my therapist, like, like a lot, and often comes up with the PTSD with like a small increments of these events. It's usually like they call it CPTSD. But what's exactly the difference of like clinician associated traumatization and those kind of like normal CPTSD with the symptoms, or some kind of like, what kind of the differences?
yeah, I think there's more research that needs to be done. I'm not a psychologist, so I can't make those kinds of claims about what kind of diagnoses people should have. I do think there's a lot of overlap. Yeah, you're right, I think, in drawing attention specifically to CPTSD, um, with these like kind of more traditional um, trauma-related diagnoses. I will say I know a lot of people even have a PTSD diagnosis. I'm trying to pull my stats right now. Yeah, so in a survey that I just completed with both hypermobile and molecularly defined types of EDS, 35% of patients with hypermobile responded that they had a PTSD diagnosis, and 24% with the other types responded that they had a PTSD diagnosis. So it's a very high incidence in both cohorts. And yeah, I mean, I don't think there's any reason to think that folks might not have both of these experiences, like a more traditional PTSD like experience and something that arises directly from the clinical encounter, like I was
Um,
describing.
yeah. And did the interview actually rise um, around the question that, like you said, the 35% is a really high percentage compared, to just normal populations. And did anyone talk about like, the PTSD actually just directly associated with like some of the clinician like negative experiences?
Yeah, I think so. Certainly, some of the patients have um, more classical sources for their PTSD, but several of the patients I've spoken with do talk about it as very, uh, I think, very comparable um, to what we were calling clinician-associated traumatization. The other kind of contrast is with medical trauma, and I think a major distinction to underscore between the stuff that we've looked at and medical trauma is the classic example of medical trauma is you wake up while you're on the operating table because your anesthesia is worn off. Where there's kind of more physical harm that's related to it, um, and that is very much, again, not that people have not had those experiences
Mm-hmm.
in my cohort, but it's certainly not the like necessary source. It's not necessary to having these types of trauma-like responses.
Mm-hmm. So, just try to confirm my understanding. And so the medical trauma, as we talked about, like more of a physical. So the clinicians associated, it's more of like the experience that directly communication with the physicians, and whatever negativity coming from, their misunderstanding or their gaslighting or their whatever attitude towards the patients. Yeah, if you correct me if
Yeah, that's
something.
exactly correct. Yeah, it arises I think this is also my source of interest, but immediately from the communication event.
Uh-huh.
Um, and you can take that kind of broadly, where there's a lot of ways other than verbal communication that patients experience this type of um, frustrating, traumatizing, invalidation, dismissal, refusal.
Mhm. Um, the things that I know that you looked even further into is the self-doubt. And I know that there's a broader uh, explanation for like, a person experiencing like a self-doubt. But the things that you look into is more of like the patient's experience of, I guess, their symptoms or can you just explain a little bit further? Because I think one of the survey that I even see very interestingly is when you try to ask the definition of self-doubt for a person and whatever their experience is.
Yeah, so this is it's something I'm currently looking at. We did a series of interviews and some surveys related to the idea of self doubt that arose specifically out of my interest in it rose specifically out of the trauma interviews. One of the things that I saw over and over again with that is this vicious cycle that patients enter when they have these micro invalidations or dismissals or macro invalidations uh, that they get in kind of surround from all their clinicians, but not just clinicians. A lot of times patients also experience this type of doubt from family and friends and even strangers, um,
Mhm.
which leads to uh, their inability or unwillingness to continue trying to seek care, to express their inner states. And this was especially worrisome to me because especially with hypermobile Ehlers-Danlos in particular, the number one way that you diagnose it is through an expression of chronic pain. Chronic pain is an entirely private, subjective experience, and uh, if the patient isn't able to express that or willing to express that anymore, there's no way for the clinician to access whether and to what extent the patient is suffering. And so that's the kind of critical nexus for a diagnosis. And so this recognizing this high level of self doubt coming out of these negative encounters, um, I think is really worrisome because it's really important to manage your chronic pain, at least in some way, even if it's not biomedical. Uh, and in the surveys, we found that 77% agreed with the statement that self doubt has impacted their ability to trust themselves as well, which I think is really interesting. And so, getting deeper into the interviews and the qualitative data, we have seen, and again, analysis is ongoing, but we've certainly
Mhm.
seen this uh, um, the impact of the kind of like clinician associated traumatization in a much broader, um, array of, medical contexts.
Yeah, so and then that is still focused on EDS or hypermobile EDS.
This interview, and survey project has both cohorts involved, and we had almost I'm actually very proud of the recruitment stats, but we had almost 50-50 for the respondents, which, if anybody else has done research in this space or even just lives in this space, you know that the incidence of hypermobile is so much higher. The ability to recruit from hypermobile type is so much easier.
Mhm.
Finding um, appropriate amount of rare molecularly defined types is really hard, which is why most of the social and ethical research on EDS conflates all the subtypes or only recruits from hypermobile and then acts as if they can say
Mhm.
something about all the subtypes.
Yeah. So does that any of these rise as like hypermobile or the other types that suddenly become more difficult in clinical settings in diagnose whatever the comorbidities or their even their hypermobile type? The reason I ask is because I feel like hypermobile is now a lot less rare because more people are understanding it more. But whatever rise upon the EDS, it's always the comorbidity and the complexity of these comorbidities that people experience.
So drawing on some of the data that we've got from our large survey that we've run with both cohorts, um, the average number of misdiagnoses looks to be around 5 before someone gets an Ehlers-Danlos diagnosis. The difference, I think, probably will end up being statistically significant. I haven't crunched the numbers yet, but it looks almost like 6 misdiagnoses on average for hypermobile versus 4 for the molecular subtypes. And I'm assuming that's very much based on having a genetic test available that
Yeah.
will definitively leave it. But an interesting correlate to that is, again, based just on the survey, it does seem like the experience patients have in clinic is subjectively seen to improve at a higher rate for hypermobile types than it is for the molecular types. And again, this is something that needs more further analysis, but my hypothesis at the moment is that um, finding out a lot of times people with the molecular types have not had the kind of chronic issues that hypermobile types have. And so finding out that you have a diagnosis that is kind of lifelong and maybe more consuming than was initially anticipated might be more startling for the molecular type patients.
Yeah. So, but it's not so much of the self-doubt or dismissal cycle, or is some of these like also contributed, the misdiagnosis contributed to that
Mm.
continuous cycle of dismissal and self-doubt?
Yeah, I mean, absolutely. That is definitely the case. It doesn't. Again, I'll have to get back to you on the differences between the cohorts. At the moment, it doesn't seem like there's much of a difference there. But yes, I do absolutely think that the self doubt contributes to a delayed diagnosis. There's a huge percentage of at least hypermobile patients who leave healthcare um, altogether, at least for a time, because of, both the self-doubt stuff. I think that's very real part of it, but especially because of the trauma from the negative clinical interactions. Excuse me. And I would anticipate that there's similar impact on patients with the molecularly defined types as well.
So do you feel like there is any kind of decrease of self-doubt if someone's getting diagnosis, or does self-doubt still continue if they already being somewhat diagnosed for part of their conditions or symptoms?
Yeah, statistically, definitely self-doubt seems to go down after diagnosis for both cohorts. But that doesn't mean that people ever feel like they're in the clear. I don't know. Again, this is something that we'll have to look into more concretely. I can certainly speak to the hypermobile data that we have, which is that a lot of patients have expressed a fear that they're actually not out of the deep waters yet. They have they've received the hypermobile diagnosis, but without a genetic test, they feel like it's still tentative. I think there's a lot of anxiety about the potential for reclassification to change whether or not the patient gets to maintain that label in the face of not just the healthcare system, but also
Yeah.
in accessing all kinds of other resources, including just socializing online.
hmm So yeah, there's seen a lot of judgments that we face because I've also presented myself online and noticing that often random strangers will also judge you as that if you're not so clear about what every symptoms you can explain. So that is awesome to really be able to interview a lot of people and understanding this. But what do you think those data or analysis that coming out that you might be able to use it for, or, improve upon for whatever experience that patient has?
So from the patient's side, in terms of improving some of the or addressing some of the trauma and some of the self doubt. On the trauma side, it definitely seems like mental health support is huge. It is like, I think this is one of the most important aspects of the intervention that I was hoping to get across with the trauma paper is that this is like psychologically, this is real. There's no reason to think that this is something that's unique to any one of these individual patients. It's such a common experience, and the impact is really lasting. And so, this is again just anecdote. I know that I wrote this in the paper, and I've said it in several other places, but I do think uh, therapy for trauma could be really helpful in and naming this and recognizing that these types of experiences actually are traumatic, um, not just aggravating or not just one-off or not just that one person, this is a systemic issue. This isn't just one patient who has this happen to them. And related to that, so on the one hand, like professional mental health support could be really useful. But then the other thing is recognizing that you're not alone, that there are tons of people with these experiences. And I'm a little on the fence about what the best way of seeking out that social support is. I did a study on the use of social media for kind of some of these reasons, and that came out last spring, I think. So if people are interested, that's also open access, but it is kind of a mixed bag. A lot of people use social media to get more information. Obviously, go into that with skepticism, but it does seem like it's a good resource, especially for things like an informed clinician in the area, who's well educated, who's accepting patients, those types of things. But then it's a mixed bag in terms of socializing, where if you can limit yourself to using social media kind of for short periods or for very specific questions, it can be really helpful. But a lot of patients, especially early on after their diagnosis, go into these uh, Facebook groups and similar spaces and encounter a lot of startling images, startling stories, and also what you were saying too, Amy, a lot of gatekeeping, and that can be really unhealthy for patients who are just trying to find some kind of social support.
Yeah. I can totally relate to, and I feel sometimes my story also can scare some people on Facebook because of severity. And so this is from the patient side of like social support and all the things that they can do for themselves, like finding a good therapist to talk to. But um, I know that on this podcast, we sometimes also invite other clinicians, and so would might be able to have clinician recognize and what sometimes they might not, they might do or they say that might causing some kind of harm or hurtful feelings, that self-doubt in the, or sprouting in that patient.
Yeah. So the first thing I would love to get across is that every time someone says pain, it's in your head. Well, of course, pain is always in your head. Pain is in your head. Um, it's not a good response to someone expressing their pain. The idea, is so and so's pain real? Well, if they're telling you they're in pain, I think the likelihood that they're actually in pain is really high. And some of this level of skepticism that clinicians bring to these encounters, which I think in large part is fueled by the opioid crisis in the U.S., um, has really swung the pendulum in a direction that's very unhelpful to probably the larger number of patients, um, at least patients with connective tissue disorders. And so many of the patients I've spoken to say that they actively don't seek out medical or don't seek out pharmaceuticals to manage their pain, even if they think that it would help, because they're so anxious about being labeled drug seeking, which a huge percentage of patients are. Um, so I think coming into interactions with recognizing that a lot of times they do have biases about Ehlers-Danlos syndrome, chronic pain patients, and maybe confronting those biases before they even see the patient could be really helpful.
Yeah. So what's some of the statement that you heard from the interview that it most like stick with you that often the patient will feel like it's most dismissal?
The thing that I don't know if this is the most dismissal, but a thing that I feel slips below the radar for most clinicians that's really important is the idea of toxic positivity, where especially for patients with disabling conditions, saying things like "you look great," "I'm so happy to see that you're not using your wheelchair." All these kinds of assumptions about what a patient's day to day looks like based on how they're presenting in clinic, especially given that I know a lot of patients, maybe the majority of patients, try really hard to look their best, present themselves in the best way, downplay their symptoms because they're worried about being labeled, like I was just saying, drug seeking, or exaggerating. Um, and treating all of those things as if they're uh, um, as if they're a reason to downplay all the other things that the patient then goes on to tell the clinician.
Yeah. So have you heard many patients talked about like any kind of misdiagnosis or diagnosis of some sort of a functional?
Yes. And I was hoping you were going to ask that because this is one of the most worrisome data points to come out of the self doubt interviews. Uh, we had, it's exactly 2/3 patients said that they'd had an Ehlers-Danlos symptom misclassified as a mental health symptom. Um, the majority of these are dismissals of these symptoms as anxiety and depression. Um, but 20% of patients said that they had some kind of somatic functional diagnosis, which is very, very high and worrisome. And again, these are not saying that they had those diagnoses, but that they had an EDS symptom misclassified as one of those diagnoses, which is very different. So these are things that patients do not feel are accurate representations of their experiences. And
Yes.
I mean, one of the things that's so worrisome about that is you it's not something you can scrub easily from your record. And
Hmm.
in sociology, people talk about um, these types of characterizations as things that haunt and overwhelm all the other types of lenses through which you can view a patient's experience. So having a diagnosis, even something as common as anxiety and depression, um, can really color the way that a clinician approaches these types of subjective complaints like pain, which, and again, by subjective, I just mean that this is a private experience and the way that you access it is through a patient's description. It's not something that you can easily measure or recognize, no matter how much clinicians believe that they can, through visual assessment, determine whether or not a patient actually is in pain.
Yeah. So I know that there are a few people that I talked with that have also discussed about the usually when before you see a clinician, like there will be some kind of assessment or like things that about anxiety and depression scoring. And what do you see about these things? Are they helpful, or do you think that from what you see of the functional issues and that might be something actually with maybe two swords?
Yeah, it is double-edged for sure. The the impulse behind offering these assessments, I can't speak to. I don't know if this is well-intentioned or not. The outcomes are both, I think, bad in exactly the way that I suggested, that having these labels right up front can really prejudice a clinician regarding how seriously, honestly, they're gonna take the patient's history, the self-report. Um, but on the other hand, incidences of anxiety and depression are really high in the EDS community, and that's almost certainly because living with chronic pain is a very depressing and physiologically anxious experience. There's a lot of very good hard science about uh, the feedback loop between anxiety and depression and chronic pain. We know that they both cause and are instigated by each other, and so getting getting healthcare, getting mental health care to help manage things like pain and anxiety and depression and pain are really important, and can be really helpful for a lot of patients. But the other thing that I'll say about that is um, referring someone to psych, which is a very common experience for a lot of patients with EDS, sometimes feels particularly flippant because such a large percentage of patients with EDS already have mental health care to manage exactly these same symptoms, anxiety, depression, and pain. So, uh, yeah.
Yeah. So I know that a lot of time, not even just doing those assessments, but going into, for example, an emergency room that can that to my experience it was pretty much like every single time I have some sort of negative experiences with the physicians or like their um judgment at front because of your gender, your different class and then everything like that. So did you hear anything about the emergency room type of situation?
Definitely. I don't have quantitative data for this, but I do know we asked we asked folks about who they felt was the least supportive or the most skeptical of all the different clinicians they'd encountered, and the emergency department was right at the top. I think these are particularly acute situations. There's not a lot of time to do a full assessment, and there are patients coming in really keyed up states from all different kinds of backgrounds. So, yeah, I think that is an especially vulnerable position for an EDS patient to be in.
For those situations, do you feel like self-doubt will plays a role in a patient's choosing this? I don't know if this comes to your mind or not, but did it actually stop someone to choose to go to the emergency room?
Yeah, anecdotally, it seems kind of I've heard both, and I don't have the like statistically, I don't have numbers high enough to say which one is more common, but I've definitely heard both patients say that they've avoided the emergency department altogether because of such, like you were saying, generally bad experiences there. But I've also heard patients say that they have bad experiences in all the other places, and so they kind of hold off on going to the
Mm.
hospital until it is an emergency, and then they end up in the ED also.
Yeah. So I feel like those are such like significant data just from what we talked about, all these, misdiagnosis of functional issues and um, psychosomatic. This is a big, painful part of, my experience too, is a lot of physicians seem not to know what the problem is it's too complex. And so they jump to that conclusion. Um, so what would be the next thing that you are interested in now thinking about talking all the self-doubt issues?
So the first thing that uh, I guess the first thing that I want to do with the self-doubt data is to write up an article about the kind of broad scope of self-doubt. I think I entered this project at least thinking that it was going to be a much cleaner and clearer set of issues. But we found self-doubt arising from all kinds of different encounters, all different types of reasons, and the kind of tendrils of self-doubt into so many different aspects of the patient's life is really, um, uh, really sad. And I think the first thing that I want to do with the data is to do a broad sweep representation, because I think that seeing all the different ways that these small incidences can have snowballing effects on the patient's well-being, like mental health, but also their ability to continue to access physical health care. I think that would be really critical. And then the other thing that I want to do, uh, um, probably second then with the self-doubt data, is look into the mental health aspects of it. I think I've already talked about this already, but this is a really critical issue um, that that's certainly not intractable, but needs real work at a systemic level. So
Yeah.
those are the next two things that I want to do.
That's I would really look forward to read some of these, especially how that can snowball into all aspects of life. That is not surprising, but also something that I feel like it's quite a shock to people who are not really living with chronic illnesses or any kind of, hypermobile EDS. And didn't really experience those self-doubt through these communications. So what would you suggest if, now knowing these patients that often getting those experiences and the physicians, I guess you can really go into a physician's office um, to really request them to behave a certain way, and then they have their own mind and then their thought process. So what might be a bit effective communications?
So, in terms of effective communication, this is actually another study that I'm running right now, is looking at what types of talk, what features of talk are associated with more positive and more negative experiences.
Mhm.
Um, so, I'll have more and different data hopefully in the next year on that. But what I will definitely say uh, first is that um, I think so. Yeah, so I think having a clear goal for the encounter. For a lot of patients, it takes so much emotional effort to get to clinic that when you finally do, you want to talk about all the different things that are going wrong with this multisystemic and complex syndrome. But if you have one goal and you can really focus on one goal for this one clinician, I think those encounters seem like they go better.
Mhm.
Um, the Yeah, the other thing is, I don't know if I even want to suggest this because it's so it doesn't speak well to the healthcare system. But another thing that anecdotally seems to go well for patients is, uh, I don't know, maybe a nicer way of putting this is letting the doctor take the lead. Um, but a lot of patients express this as making the doctor think it was their choice. So if you're going in and you have an intuition that this is the diagnosis or this is the treatment option that's going to be best for you, um, presenting, kind of leading the clinician into that direction instead of saying, "This is what I know," or "Someone online told me," or a lot of clinicians, I think, bristle at having diagnoses come from specialties that they don't think should be offering the diagnosis.
Mm.
Um, so I don't know. It's maybe not a great answer, but this is just something that I've heard a lot from patients.
Well, yeah, I think actually that's a safer answer to the fact that a lot of clinicians doesn't really like to take that lead. But I know there were uh, plenty of physicians that I encountered with that would love to learn about things, and they like to see actual like data or literatures that you find that is correlate with whatever your symptom is. Yeah, I hope this might be something. And I really love the one that you said it was like one goal for one clinician. I know sometimes we will go off the tangent and just go on and tell our life story, and it doesn't really help the physicians to really know and pinpoint. Yeah.
I will also say for both sides, for both patients and for clinicians in the audience, there's EDS Echo, which is an online program of doctors teaching doctors. It is through the Ehlers-Danlos Society. I think that's an incredible way for clinicians who are interested in uh, learning about the research, learning about the patient population and presentation, all that stuff. There's all kinds of different materials there, lectures that you can watch there. And for patients, there's a lot of other really great researchers who are talking about things like what's the best way to present in clinic and what's the best way to be taken seriously. There's a bunch of even psychologists who have been doing that kind of work who all have talks on EDS Echo for patients too.
Yeah. I will have to check it out too. And I think that ongoing education for doctors are kind of really important, because if we kind of stop learning, and that's where I met physicians who were like, "You're too young to have too many problems." So I know that you have interviewed a lot of people. So can you share a little bit just on the broad, like, population of how how much percentage there is, like, age-wise or like, geographic?
Yeah, so in terms of the demographics, this is a real problem, especially for the hypermobile type, because there's no reason that we should see the kinds of skews that we do see in the actual data, meaning patients who have managed to actually succeed and get a diagnosis. There's huge disparities in terms of gender and race, ethnicity. Which is really strange. I know there are some physiological mechanisms that might make it less likely that male-bodied individuals experience the same kinds of um, symptoms that would lead them to pursue a diagnosis.
Mhm,
But it seems almost impossible to me, as someone with a background in anthropology, kind of on the social side of things, not to see this as also a social issue.
mhm,
Uh, the race thing is also really startling. So for anyone who doesn't know, the percentage of female individuals with female-embodied individuals with hypermobile diagnosis is uh, magnitudes higher than male-bodied individuals. It's the same thing with white or Caucasian patients. There's a very low percentage of patients from non-white populations who manage to get an EDS, hypermobile EDS diagnosis, um, and and actually not just hypermobile EDS. There, I think, are some real physiological reasons that are related to bias in the medical system, because skin findings have been typified on white patients, so they look different on non-white patients, and I think that's part of it. But again, it's really hard to look at these incredible skews and not think that there are deeper problems too, probably related, at least in part, to the increased likelihood that non-white individuals have in getting their pain dismissed by clinicians.
yeah. Um, I feel like that's always like systematic issues, because, race and then genders seem to clinicians like paint the picture differently as well. I never thought about the skin finding would be like that important at the program, but I can see how that can affect different people, especially with different colors, and the textures would might be something different. And then hopefully the geneticist was able to look further into it, and to kind of like close the gap a little bit. So what about the age? Like, because I noticed how different it is with my mom to be here taking care of me, and she is not English speaker, but she is definitely a great patient advocate. So things, there are a lot of rising diagnoses in recent years for hypermobile EDS or the cohorts. So do you see any of these younger patients that actually getting a little better experience because of maybe their parents or guardians and that able to help them speak up? And
Yeah, I don't know if I have a good answer to that. I know that certainly some of the older EDS patients I've spoken with feel like that is the case. I think generally that is the trajectory for a lot of rare diseases, where the first few generations have to do a lot of the groundwork, and then later generations can benefit from having maybe a more knowledgeable clinician base or having access to more resources, or more education materials. So I wouldn't be surprised if that is true.
well, so closing up, just for looking to, the future, like what you think that right now, like the last words that you wanted to say to patients and patients, caregivers, like they can see some kind of hope or changes in the near future for the medical community handles things or their for their experience to be slightly different.
Um, so in terms of hopeful things, I do think that there is a growing body of research and researchers working in this space. I'm thrilled every time I find out that there's a person who's both a patient and a researcher, who that number also seems to be skyrocketing, and I think that kind of involvement, kind of on the science and the advocacy side, is going to make huge differences for patients' experience in the near term future. Um, the other thing that I like as a kind of takeaway, the most the most important thing I think is to recognize that uh, patients are not alone. You're not alone in terms of your physical symptoms. You're not alone in terms of the trauma and the misdiagnoses.
Mm.
Um, and you, especially with the hypermobile type, you might not even be alone, like even in your locale. But for folks like folks who live rurally, or for folks with the molecularly defined types, I do think that finding social support, maybe through online communities, maybe through EDS society events, maybe through some of the other like I've been working with Annabelle's Challenge recently. They're phenomenal. I know there's also the VEDS movement in the US. Um, all these are resources, not just to think of these not just as resources for science and knowledge, but also as social support too.
Yeah. Well, I'm very thankful for all the great work you have done, and all the data for patients to also know about. It's really important to see there is a change in the whole entire healthcare system. It's slow. I do noticing that, and then I feel like a lot of these data also makes us feel like particularly we're not alone in this whole entire fight, and we can kind of like communicate and then support each other. So yeah, I'm very grateful you're being here and then talking about your researches and all the interviews that you have done. And thank you so much.
Thank you so much. This was a real pleasure.
Thank you for joining us on this powerful episode of Hidden Diagnoses Impact. I am incredibly grateful to Dr. Colin Halverson for sharing his insights into clinician-associated trauma, diagnostic delay, and the systemic biases so many patients face, especially those navigating rare, invisible, or misunderstood conditions. If this conversation resonated with you, please consider supporting our growing mission. We're in the early stages of building a nonprofit to uplift patient voices, educate healthcare professionals, and creating inclusive spaces for disabled artists and advocates. Your donation at inclusivibe.betterworld.org will help us continue this work. From producing conversations like this one to building programs that drives real change. Don't forget to subscribe, leave a review, and share this episode with someone who needs to hear it. And as always, your story matters, your health matters, and you're not alone in this journey. Until next time, stay informed, stay empowered, and stay connected.